Hi, I'm Dr. Gheorghiade. I just presented the ASTRONAUT trial at the late-breaking clinical trials. I'm from Chicago. I'm a professor at Northwestern University. First of all, let me tell you why ASTRONAUT. As we probably everybody knows, in the United States, once you admit a patient for worsening chronic heart failure, the post-discharge event rate is unacceptably high in spite of all the available therapies and can reach a mortality of 15% and a rehospitalization rate of 30% within 60 to 90 days post-discharge. So clearly we need new therapies to improve this post-discharge outcome. ASTRONAUT was about aliskiren, a renin inhibitor that was added to patients hospitalized for worsening chronic heart failure at the time of their stabilization that occurred an average of 5 days after admission. Those 1,000 and approximately 600 patients were randomized to aliskiren plus standard therapy that included ACE inhibitors, ARB, beta blockers, MR antagonists, and so on, and compare with the placebo group that received similar therapy. Although we're hoping to see a change in post-discharge event, when we look at the primary endpoint, namely mortality and hospitalization for heart failure, there are no differences between the aliskiren group and the placebo group at 6 months. However, it was interesting to see that patients randomized to aliskiren had a much lower pro-BNP compared to the placebo group, suggesting what? That aliskiren prevented progression of heart failure, but at the same time, this prevention and progression did not translate into improved outcomes. It was also interesting to see that patients with diabetes, representing 40% of the patient population, had more side effects like high potassium, low blood pressure, a decreased worsening renal function in response to aliskiren. So although the study is negative or was negative in the sense there are no major differences in clinical events between the aliskiren group and the placebo group, raised the hypothesis that renin inhibition with aliskiren or another similar compound may be promising in patients that are not likely to develop side effects like renal insufficiency, hyperkalemia, or a drop in blood pressure. And those are the patients who have diabetes. So again, the hypothesis is that in the future, we probably should study renin inhibition in patients hospitalized for heart failure, optimize another therapy, and this intervention might, just might, improve outcomes. Why we're insisting and not giving up on therapies? Because, as I said before, the message, another important message from ASTRONAUT, is that in spite of enrolling patients relatively stable at the time of discharge, the event rate, in spite of all the available therapies, was unacceptably high. In fact, we had an event rate, mortality and hospitalization at 12 months that reached 40%. So obviously, we have an emergency in our hands, and we need to look at new interventions to improve this event rate. Thank you very much.